Yes, I'm going to ask Dr. Holmes, but let me lead in with this. I've helped pass the voluntary rural emergency hospital program, and I thank the senator from Nevada for bringing this up. Since January, several hospitals have become rural emergency hospitals. An article from St. Mark's Medical Center in LaGrange, Texas, was titled, quote, Texas Hospital to Keep Doors Open with Rural Emergency Hospital Designation. Another article about the Holly Springs, Mississippi Hospital quoted a hospital official saying, quote, we expect the new designation to improve both the financial and the outpatient capability for citizens of Marshall County. There are several more examples. So, Dr. Holmes, what hospitals are prime candidates to become rural emergency hospitals, and what would be the alternative for hospitals if a rural emergency hospital didn't exist?
Well, the alternative is, for many of them, closure. And so at least the REH program offers them an opportunity to provide emergency department care to their community. That's usually one of the first instances that we notice when a hospital closes is someone needs an ED service, and within 3-4 days it's not there during a closure. Dr. Herman, I think, touched the main points for which hospitals would be strong candidates for REH conversion. These would be places that have low inpatient use, probably a low ED volume as well, and have been financially struggling.
For you and Dr. Herman, I support the Rural Community Hospital Demonstration Program. It's a key tool to support rural hospitals and maintain access. Currently, the Centers for Medicare and Medicaid Services is underutilizing the program by leaving 5 of its 30 spots open. So do you think that we should be underutilizing a cost-effective rural hospital program like Rural Community Hospital Demonstration?
Certainly not. Certainly the need is there. I think what we would need to do is go back and take a look and say, why haven't 5 other hospitals put into that? Sometimes the regulatory hurdles are so complex that they're either hard to understand, or if there's 20, you can meet 19 of the 20 requirements and you can't meet that last one. My suggestion would be have an outreach program from CMS to many of these rural hospitals and try to facilitate the application rather than just sending it out.
You got anything to add, Doctor?
I do not. That's a great answer.
Then let me go to you two again. I have championed efforts to ensure Iowa physicians get paid fairly for the health care services that they do. Iowans pay the same amount of money on Medicare as everyone else in the country, yet rural states like Iowa get shortchanged when Medicare pays Iowa physicians less than a lot of other states, and I'll use New York and California as an example. Lower reimbursement has several impacts, influencing a physician practicing in our state. The labor shortage of physicians is not local but national, especially in the age of telehealth. There are many unforeseen costs of physicians face by working in rural areas, namely travel time, transportation costs, and broadband. Congress has established this geographic practice cost index that we call around this town as GYPSY. That floor is to ensure rural state physicians receive fair reimbursement. At the end of 2023, this is going to sunset. How does the GYPSY floor protect access to physicians in rural areas?
I'll take that one first, I guess, and you can build on it. I think an important thing to remember about where the GYPSY comes from is it's based on historical and longstanding patterns, prior to its introduction. So a state that has low wages gets a lower GYPSY, which means lower revenue, which means they pay lower wages. So there's a cycle there that's sort of self-fulfilling, and I think we've seen some examples where CMS in particular has tried to up some of those price indexes, and it'll be interesting to see what kind of impact that's had.
Do you have anything to add to that?
Yes, I would say that it used to be in the 1960s when you evaluated a physician's standard of care, it was based upon the community. Now a physician's standard of care is based upon the broader community of the United States. Their health care costs to run a practice are much more reflective of the broader healthcare costs across the United States than something that happens in Osage, Iowa. So I think there needs to be something done with that.
Thank you, Mr. Chairman.
Thank you. When Senator Lankford came in, he actually bumped